Hello and welcome, everyone. Thank you for joining us for the Guiding Principles of Recovery webinar. Whether it's morning, afternoon, or evening, where you are, your presence here matters. I'm Lindsay Fankovic. I'm the Director of Strategic Outreach at Faces and Voices of Recovery, and I'm honored to moderate today's event. This series is proudly hosted by the Colombo Plan, the International Society for Substance Use Professionals, ISSUP, Faces and Voices of Recovery, and the Global Recovery Network, GRN, organizations working together to strengthen recovery systems worldwide. Whilst we are waiting for a few more to join us, I will begin by saying a little more about ISSUP, a membership organization for the global substance use workforce with over 35,000 members worldwide. Quite impressive. It is an international network that unites, connects, and shares knowledge across the substance use prevention, harm reduction, treatment, and recovery support workforce. ISSUP's global mission to make the work of members as impactful, accessible, and effective as possible. They do this by making it easier to discover and share evidence-based knowledge, best practice, training, and networking opportunities. If you've done so already, make sure to check out ISSUP's website, issup.net, where you can find a plethora of information on how to sign up for free membership, learn about the multitude of different webinars and training opportunities, resources and publications to enjoy and to bring back to your communities. You can also watch past recordings of webinars, including this series, and again, see future event listings. I'd like to thank ISSUP staff for providing technical support for this webinar. If you don't know, this is a 6-part series taking place every other Tuesday, concluding on September 30th, which happens to be International Recovery Day. Each phase of the series focuses on building knowledge and capacity across 3 different areas. 1, core foundations for recovery. 2, advocacy 101. And 3, leadership development. Today's session continues the launch of our foundation phase. Additionally, a few little housekeeping things for you to be aware of before we kick off and I introduce our presenters. Today's session is in English with interpretation available in Spanish. Please check for the link in the chat to access the Spanish interpretation. And this session will be recorded and you will receive slides, video, and resources via email after the session. And definitely make sure to use the Q&A box to submit questions at any time. I myself, as well as some of our staff from ISSUP, will be monitoring to help answer as we go along in the presentation, but we will most definitely save time at the end for Q&A with our presenters. It is my pleasure to now introduce these wonderful 3 presenters. We have Boro Goic, Dr. David Patton, Mokai Nietzsche, to bring to us today for this amazing presentation. Boro Goic has worked in the recovery field since 2004. Following his own rehabilitation, he founded NGO Celebrate Recovery to support individuals and families affected by addiction and has helped establish several other recovery-focused NGOs in the Balkans. Since 2013, he has chaired Recovered Users Network, RUN, a platform amplifying the voices of former drug users. Boro is also an active advocate for recovery-oriented drug policies at the national, European, and UN levels. We also have Dr. David Patton, who is the Associate Professor of Criminology at the University of Derby. His research centers on the lived experiences of people in recovery from addiction and past offending, co-producing new approaches to transform the criminal justice system. He emphasizes the role of hope and opportunity rather than pain. Its key motivators for lasting change, highlighting broader social and structural influences. Dr. Patton also directs New Central Media, a hub that partners with marginalized groups to explore community-based solutions to issues like isolation and materialism. He is currently leading an international photo voice project with the recovery organizations to share recovery strategies through photography. Mokai Nishis is a research officer at the Center for Hate Studies, University of Leicester, Secretary General of RUN as well, and a founding member of the Global Gender Committee within the World Federation Against Drugs. She brings decades of active engagement in the field of drug policy and recovery from addiction. Her current research explores the lived experiences of individuals in recovery and gender recovery pathways across 9 European countries, focusing on recovery capital and stigma's role. And now it is my pleasure to hand over the webinar to esteemed presenters. The floor is yours.
Lindsay, thank you very much for this comprehensive introduction. Yes, hello to the whole audience. I don't see really how many members are following this webinar, but I know that we can have in the next 1.5 hours good time and talking about recovery. So I will start to share a presentation. We will have one presentation and we will exchange us on this presentation with different views. We shared it. So basically when Lindsay contacted me and asked me if I want to participate in these different webinars, so we've been looking what we can speak about, you know. So these guiding principles of recovery was something that, let's say, was very attractive, because we have and will present today one document which is called Global Position Paper on Recovery. So basically, before I start presentation, I would like to thank really the ISSUP for organization of this webinar, and of course Faces and Voices of Recovery from United States, and let's say the Global Recovery Network 2 and Colombo Plan. So basically, why global position on recovery? Why we have that paper? So we can talk a lot about recovery from own perspectives, yeah? And we can talk a lot about recovery and say what is our perspective on everything. But basically what we wanted is to see what many organizations together has common when it comes to this, to recovery. So basically, I'm in this field for 20 and some years, you know, and let's say that we all have different statements, and different statements sometimes provide different information to people in support, to different, we can spread different informations as our own views. But somehow we came to idea, let's connect in between different organizations, between recovery organizations, and let's see if we have some united voice about recovery, and to present it as some principle that will unite the movement, that will not be our own views, then views from all the people. So basically, sorry. Okay, next slide is a little bit about Recovered Users Network that Lindsay introduced, that I'm part of that political platform that is established in Belgium in 2013, and now it's based in Sweden. So basically we connect 63 different member organizations, but the important part of the Recovered Users Network is that we have experts and also researchers that are part of our network. So basically the main thing why we created that network back in 2013 was to provide political voice to recovered users and recovery organizations, but also to contribute to policies and to raise the voice of recovery movement at national, EU and UN levels. So why that everything? Just a short background of that, you know. So we've been everybody working in our fields and working on the grassroots levels for many years, but we saw really that when it comes to the different policies, when it comes to the different advocacy work, that we don't have people who are really actively advocating for that what happened in their lives. And I think this is very important thing, that politicians and policymakers and people who are deciding what will be in the drug world and drug fields needs to hear voices of people who have been struggling inside of the drugs came out of that problem and having now potentially very, very good life and are involved into the society. So basically we organized the Recovery Users Network not to have some study visits, not to exchange the best practices. Then we saw that there's a really a need in the recovery movement to have a recovery champions who will speak from their own perspective and perspective of their organizations in front of people who are decision makers, who will build some kind of documents and presenting to a different policy makers. So basically, this is advocacy work that we are doing towards recovery-oriented policies, and it's combined many times between evidence-based data and lived experience narrative. So for many years, we saw that many good testimonials and very good narrative that people with lived experience can present can really be very inspirational, and it can really bring understanding inside of the people. But we saw that only narrative and only testimonials cannot sometimes change the policies. So basically why we involved the researchers in our work was to bring also evidence-based data, what we really know about recovery in the numbers, how recovery really works and what outcomes brings. So basically when we combined that with lived experience, we saw really that some changes are presented there. So, and now about back to global paper on recovery. So basically why we organize that everything is to facilitate a cohesive approach, to contribute to the development of unified approach and global position on addiction recovery, to unite voice and raise awareness, as I talked before. So sometimes voices of people in recovery are just different. And I think this webinar series will cover also different recovery paths. And if we go a little bit deeper inside of the movement and talk with the different people from different continents and different recovery paths, we will see that we are really not always united when it comes to what message we are providing. So I'm not saying just about message recovery is possible and that drug use is a recoverable condition. I'm going more deeply and thinking what really unites us and about which things we can say, okay, this is our common approach. And that was one of the reasons why we created this global position paper on recovery. And of course, this is commitment to work together, and because we wanted to create some international platform that we can share, and that the people from different organizations who are not able always to participate in different conferences have some kind of tools and can work with that in some advocacy work. So what we did, we created a survey and we asked 50 different experienced organizations or networks that we choose mostly purposely to respond on the 4 themes and to respond with the 3 statements. So basically we had more than 600 responses, everything, and also we had the different governmental bodies also as observers before we did everything with that paper. So four questions that we asked in that survey what are the main goals of recovery? What do you see as a main mechanism and pathways that help to promote growth in recovery? What barriers do you see slowing or preventing growth in recovery? And like a 4th question was, how would you improve the recovery system in your country to create better outcomes for those in recovery? And before we go to the real methodology that David will cover, as you see, we get a lot of responses. And it is really was good to see how much varieties was between different answers. So I would like to go through the different responses just for you to see what people are responding. For example, when we asked for the question, what are the main goals of recovery? So I will take a few minutes to read this all the responses. So people from the different organization response. The goal of recovery is to improve people's health and well-being and to achieve the greatest possible level of self-reliance and autonomy. Main objective is returning to be autonomous, responsible, with a balance in all areas of his life. Without the clarity that the goal of abstinence provides, there can be no recovery. Abstinence does not exclude medication-assisted treatments. Recovery is much more than stopping substance or behavioral abuse. It is seen best when one is fully integrated back into society as a productive individual. The ultimate aim is the cultivation of long-term wellness, spanning physical, mental, and social dimensions. And also, acceptance is one of the keys to recovery, to build relationships, to make amendments, and to live honestly. So really different types. And also we had a lot of responses regarding, is the abstinence the clear goal for recovery or is not? But I will not make a conclusions now. I will just read from the next question. So what barriers do you see that preventing a growth in recovery? So integration of recovering drug users requires proactive accountability mechanisms on behalf of all community stakeholders. Absence of messages encouraging change and recovery, people respond. Competition among organizations and low recovery capital was also one of the answers. Maintenance services. I would suggest maintenance services should be no longer than 3 to 6 months. Very interesting response. The biggest barrier to recovery is the confusion around safe use of drugs. Acceptance of recovery being anything that people say it is or define for themselves is nonsense and does a harmful disservice to those who live in the world of controlled substance use. A very interesting response. Recovery capital is too often seen as a property of an individual rather than a recovery. Unbalanced government strategies funding that only consider treatment rather than recovery needs a focus on recovery embedded at every level. Skepticism also and lack of access to affordable housing and stable employment and limited availability of community-based support services. Also, when we ask a question about mechanism and pathways that are needed to provide, people have been responding. To promote recovery, there should be a global campaign on the meaning of recovery capital, types of recovery capital and strategy for creation of recovery capital. Addiction affects multiple domains, physical, social, cognitive, and spiritual also. So pathways mechanisms that address multiple domains are essential. Incorporating recovery as an integral part of any public health system in a logic of continuity of care. Addressing the whole person. Raise consciousness in society aimed at destigmatizing recovered populations. The role of people in recovery and recovery support services. So I've been going through that just to see the differences of all the responses that we have. And now I'm giving floor to David Patton that will go a little bit more to the methodology and to the pillars that we get when we went through this research. So please, David.
Thank you, Bora. That's great.
I will share the slide. Next one.
Yes.
Here.
Okay, so I've been invited just to talk in a little bit more detail around the research methodology that we did and the rigorous process, because underlying the document is kind of knowledge production. So anybody could write a report, which can be their own opinions, and we wanted to ensure that the global position paper was underpinned by a rigorous methodology. And so to start right from the outset, it started in March 2023. And so Bora Mulker and I were at the CND in Vienna at the United Nations. And for anyone who's been there, there are people from all over the world. and you attend lots of different seminars, workshops, and people are talking around the work that they do, the models that inhabit their practice. And so it's this melting pot of kind of learning and sharing of good practice and ideas and exchange. And it was at that CND in 23 that Malka had the idea to do this global position paper, because what you're also aware of at the CND is that people, organizations, countries, their understandings of recovery is different, which isn't a problem. There's room for diversity in this field, and that should be welcomed. It shouldn't be a one homogenized approach or understanding. But what tends to happen is that there become silos. And so people kind of work in little cliques or kind of exclusive groups. And what you can observe in this field is that all of the prevention people tend to stick together, and all of the harm reduction people stick together, and then the treatment people kind of tend to stick together, and likewise with the recovery people. And so we're all in our own little echo chambers, hearing what we want to hear. And so that wasn't the approach that we decided to take with this global position paper. We wanted it to be democratic. We wanted it to be diverse. We wanted to hear the plurality and diversity of views from people within those different paradigms and those different perspectives. So we decided to make a survey. Now, as Burroughs said, we just asked a few short questions that were open-ended. So when you're doing research, you can do two types of questions, typically speaking. One is open questions and the other is closed. When you're asking a closed question, that would be where you're asking the question, but you're giving preset options or answers to that question. So, for example, which political party did you vote for in the last election? And then you would list the parties underneath. Or what are your views on a particular type of food? Very delicious, likable, unlikable, disgusting, so on and so forth. So the answers are predetermined. That would be called a closed question. Whereas in this survey, what we did was we had an open questions so that people were able to come and respond with whatever response they wanted to give. We wanted to be very clear that we did not want to influence or shape their response in any way. And that's why we kept a number of questions short, and also the wording of the question was very much open-ended around, what are your views as to what are the main goals of recovery, so on and so forth. So once we decided on the survey and it was shared with all of the people that were involved in that kind of collaborative process, we distributed it to who were some of the key kind of networks, organizations, people working in the field. And again, it went to kind of prevention, treatment, harm reduction, and recovery, so that we were getting a range of views rather than just emailing the survey to our friends or people who we knew that might agree with our own views. So I'm getting a little bit of an echo. Yeah, it's still doing it. Is it echoing for other people? No, shall I continue? Okay. So we sent it out and we got 50 completed surveys. And again, as I was saying, that was from a range of different organizations with different paradigms, different models of practice, and different values, a diversity of values in their practice. So we invited 12 people as representatives of those 4 different main groups: prevention, treatment, harm reduction, and recovery, to convene in Madrid in October 2023. And what we did there is, when you're analyzing qualitative data, which was essentially what we'd got, when you ask closed questions and preset the answers, that's when you would generate statistical responses. But because we had open questions, essentially what we had was short paragraphs in terms of the answers that were given. So they were written and they were qualitative in nature. So in order to analyze that data, you have to read through the responses you get. So for question 1, we would read the 50 responses for question 1. and we would read it a second time times 50. And we'd go, okay, which issues, what themes are coming up repeatedly throughout those 50 responses? And then we would kind of highlight that, and we would almost tag those types of themes and give it a name, whether that was kind of recovery capital, strengths-based approach, or whatever the theme may refer to. We gave that qualitative sentence a theme name, and then it's almost like you put all of those quotations, all of those statements that match that theme into a bucket. And then you'd move to question 2. You'd read them all through, and then you'd pick out the themes and put them in the buckets, metaphorically speaking, that all matched. So by the end of it, and because we had the group of 12, and each group we split up into smaller groups, so that we had 3 groups of 4. So we had in each group prevention, treatment, recovery, harm reduction. So it wasn't that all of the recovery group people analysed it together and all of the harm reduction people. Actually, in every small subgroup, we had those range of voices and perspectives to ensure that in terms of as we're coding the data, as we're coding the statements, that all of those perspectives are being picked up on and then put into the buckets. So that was quite a rigorous and quite a long process. It was a lot of work reviewing 50 responses. So we completed that. We had all of the statements in the buckets. And then in November 2023, there was a group of senior kind of academics who then reviewed, okay, we're now going to read through the 50 surveys, look at the statements that are in the buckets. Are these the themes that we saw as well? Would we agree that the buckets represent the statements that people said? So we had that verification step built in. And only once that was verified did the small team then begin to draft the document. How do we condense the views that were shared into a draft document? And so that was then presented back to globally for comments and discussion and amendments. Again, feedback. Actually, does this resonate with the views of the global community? And so amendments were then made before presenting the following year at the CND in March, the United Nations in March 2024, where we launched the global position paper. We had a number of governments there supporting the event, and UN, UNESCO were in support, the UK government, Serbian government were all there in support. And so at that point, we then launched the survey for signatures. If people read that global position paper and agreed with the sentiments, the expressions within it, did that feel like it represented the views and the practices? Can we sign up to this kind of united consensus? And also, hopefully, it'll be capacity building for some who saw the document as a learning kind of tool as well. So that was the process in a nutshell. So, Borough, would you go to the next slide, please? Thank you. So we split it up into the pillars, which link directly to the questions. And so we asked people in recovery, what did they regard to be some of the strengths that they saw occurring? And we had a number of dominant themes there. I'm just going to talk about some of them in this presentation because there's not time to talk about them all. But a dominant theme that came up again and again in people's answers was around recovery capital. And so in recovery, there is the research talks about there being 3 dominant forms of recovery capital: personal capital, social, and community. And so people observed in their work through their organizations with the recovery communities all across the collection of countries that we had, that people accrued these strengths, that they accrued kind of that capacity to build new relationships, for example, relationships first and foremost with themselves, with loved ones, with family members, romantic partners, rebuilding relationships with children and family members, building new relationships with work colleagues as they gained employment, and also through the community, they increased their sense of belonging. They had an increased empowerment and esteem that I am a citizen of my community, I belong here. And as they began to participate in that community, their community capital grew. So there was lots of themes and comments from everybody around the growth of recovery capital. Another dominant theme was the recognition that the recovery journey is a flexible, dynamic and nuanced process, and that actually, when you look at people at different stages of recovery, there's this kind of factors that were occurring earlier in childhood or adolescence were then having an impact in kind of later life, in adulthood or in midlife kind of periods, and understanding that something that was holding people back in midlife actually was linking back to maybe childhood or early adolescence, and so that needed resolving. And so we understood that recovery is not a linear journey, it's not a straight, direct, uh, always progressive journey. Sometimes you take a step forward and then somebody takes 6 steps back. And so it was acknowledging also that recovery is not just about the cessation of substances, but actually it's about the improvements in health, improvements in their well-being, in their quality of life, in their sense of empowerment, and becoming this better self and living this better life that they're able to recultivate. Another dominant theme that people spoke about was acknowledging a public health perspective and recognizing the need for a continuum of care. And I think this is something that was in the original kind of offerings globally, but over time, especially in white Western countries, the treatment offer and the care offer, the time in which people are funded to participate in therapeutic and recovery-based communities has got shorter and shorter and shorter as the budgets and the finances have been cut. Actually, we've moved, especially in my country, I'm from England, to very short, acute time periods. So people go through treatment and are expected to come out with it within, typically 3 to 6 months. And so we know that the average addiction career is kind of 28 years, but somehow we can sort all of that with a magic wand within 3 to 6 months in England. So we know that's not really true. And so in order for recovery to happen and be sustained, there must be an offer of a continuum of care, that it's a long-term offer of support in order to really sustain recovery. And then another dominant theme was around stable recovery. And this has come out in my own research that when you interview people in recovery at different stages, so the Betty Ford Institute spoke about early recovery, which was the first year of recovery, the first 12 months. Then the sustained recovery, years 1 to 4, and then the stable recovery, which is years 5 plus. So preceding this period, you've got the 28 years of addiction, 4 or 5 attempts at stopping and maybe accessing treatment, either in the community or in residential. And then from that last attempt, it's then another 5 years. So we can see that it's a long-term process of change. But there's something about people who make it to 5 years plus. And research shows if you can get people to 5 years plus in recovery, then research shows that they are better than well, that actually their levels of quality of life, their levels of well-being, some studies show is higher than people in the general population. Now, what this shows is that recovery, therefore, is regenerative, it's restorative, because you're going from people's quality of life and well-being being on the floor upon entry into recovery to within 5 years it being better than the general population. So what we've got is powerful in recovery, what we've got, it works and is transformative. And that links really to the next theme, that recovery is possible for everybody, that it really is about people rediscovering self or their new self, and now being so empowered and having a sense of agency in their own lives that they're able now to self-direct, to confidently make those decisions and to strive for their full potential, to set goals, and not just to set them, but to achieve them as well. That was really important in terms of people's responses. And finally, the final theme was that most people in recovery aspire to kind of resolve their substance use dependency and to lead drug-free lives. And again, this can be a controversial, sensitive topic for some sectors, but it's that view that people are always aspiring to have the high level of quality of life and well-being, and that for the majority that tended to be abstinence amongst our sample. So thank you so much, Boro. I'm now going to hand over to Mulka.
Thank you so much, David, and thank you, ISSUP, and also Faces and Voices of Recovery for making this webinar happen. It's really a great honor to be here with you today and also to speak about the topic that kind of lies in the very heart of this global position paper, and those are the barriers that people encounter to access, maintain, and sustain recovery. And it's also really kind of a matter of effective, equitable, and even maybe humane approaches to addiction recovery, to the policy, to community, and barriers that kind of hinder processes for people to recover. And I love this slide because I just want to say, first of all, and what we got in our paper is that recovery is not a linear path. It's not one size fits all. We cannot McDonaldize recovery services, and it's not just about the abstinence. It's a lot more about building meaningful lives, kind of strengthening relationships, restoring the purpose, and all of the things that matter in life. But these journeys are often made harder, not easier, by the systems that are meant to support them. And I would say that community and policy barriers play a pivotal role in limiting the research, reach, effectiveness, and everything around recovery efforts. And we cannot speak about recovery in isolation from the broader social determinants of health, such as housing, employment, even discrimination and access to care, nor we can ignore the ways that that fragments policies and disconnect services that prolong suffering and prolong addiction that kind of progresses to acute state. And if you're serious really about promoting sustained recovery, then we must go beyond just treating the symptoms of addiction. We must rebalance our national, local strategies, give equal weight to both treatment and long-term recovery supports, but also we need to design the systems that allow individuals not just to survive addiction, but to thrive to recovery. And that is what really matters and how we can address these barriers. And I would say that one of the most powerful ways to do this, and why we started this position paper, like Boro and David said, is we wanted to improve the greater collaboration between clinical, outpatient, inpatient services, post-treatment recovery support sector, peer-led, voluntary, every service that is available to kind of support someone and not pose a barrier to recovery. But let's be clear, recovery is a complex and, like David said, a really long process, and the obstacles people face are many. And these challenges can really be categorized in our paper in four key barrier areas that I will speak about today. And next slide, please, Dora. And I just want to highlight that we got these results based on the thematic analysis, like David said, which means that the majority of people who were our participants in the research agreed with these key areas as really important. So the first one is, of course, stigma and discrimination, something that has been long recognized as one of the greatest barriers. Second one, access to treatment and support. Third one, diversity of vulnerable groups. And the fourth one, education and awareness that needs to really be on a much higher level. And I will just touch upon each of these briefly. Next slide, please, Boro. And let me start with stigma. And stigma has been recognized as a single most pervasive and I would say corrosive barrier to recovery. And stigma associated with addiction continues to silence, to shame, to isolate people, and it deters individuals from seeking help. It fuels self-stigma, impacts the families, and also it kind of sleeps into the institutions and it fuels the institutional behavior and how services are delivered and how people in recovery are perceived. And we need to recognize that to tackle these issues, communities must implement anti-stigma strategies, and these should go beyond awareness campaigns only. They must be structural, embedded in practice, and this must include the training to deliver these stigma-informed care, embedding recovery stories into public disclosure, like Boro said, and ensuring that people in recovery are visible and positioned as leaders and advocacy champions. And we must create these environments and spaces to reduce victimization and challenge social inequalities. And this really means that we need to promote the access to community resources, employment, housing, meaningful social roles for people at all stages of recovery processes. And as we heard David, recovery is really it takes a long time for a person to recover, to start the recovery processes, and we need to really ensure that reducing stigma is not about kindness, it's about justice, it's about social justice and ensuring that every person in recovery has the opportunity to really fully participate in society. And I would say that the second one, access to treatment and support, is the barrier that we really know about for decades now. And access to high quality treatment is really deeply unequal, whether it's geographical location, financial constraints, or cultural language, even gender. We had a session today which really confirmed the things that we wrote, that were written and provided for the global position paper, that women do not have equal access to treatment and support services. And we know that treatment alone is not enough. Sustained recovery really requires access to broader range of supports, and as David said, we call it recovery capital, includes housing, employment, education, social networks, mental and physical health care, and so on. And it's not acceptable to treat addiction in isolation. And the reality that we saw really in these answers that we analyzed, the reality is that individuals really often return to environments shaped by poverty, trauma, and disconnection. And if we do not address these kind of structural conditions, then recovery becomes a fragile and uncertain process. And I would say also that recovery support services, peer mentoring, recovery housing, recovery employment support, and community recovery organizations really play pivotal role in this, but they're not recognized in the treatment system and recovery system as equal. And the third one is diversity and vulnerable groups. And I want to highlight that there is really a need to tailor all of the recovery efforts to diverse and vulnerable groups. And we saw that in almost every response that we got. And as I said, recovery is not a one-size-fits-all model. We must recognize the additional and often kind of compounded barriers faced by certain populations. And this includes, as I said, women, especially women who are pregnant and mothers, older adults, people experiencing homelessness, those with learning difficulties, LGBTQ population, and also individuals who are involved in criminal justice system, and those with co-occurring mental and physical health conditions. And these groups really often cannot go through the cracks of standards and treatment models, and they're either excluded from the services or encounter systems that do not meet their needs. And these cultural and trauma-informed and gender-responsive and inclusive programs, they must be designed not as optional. They must be designed as fundamental. And when we design these systems, they must be inclusive for the most marginalized groups. And the fourth one that really, I think, was also recognized by the majority of organizations is the education and awareness. And they play a critical role in breaking down the barriers to recovery, especially within the communities and within the service systems. We know that training peers, professionals, and frontline workers using recovery-informed curricula also helps raise the quality of care and increases empathy and builds confidence in working with people who use drugs and people who need recovery. It also helps build alliances across the sector, for example, improving collaborations of criminal justice systems and treatment staff through mutual education. And this can really reduce the punishment-based approaches and increase the diversion to recovery pathways of people who are encountering criminal justice problems. And education is not just about the knowledge, it's about changing the attitudes, it's about improving the coordination and fostering a shared commitment to support long-term recovery. And I would conclude about the barriers to just say, and also I think David and Bora will say a little bit about this. We need to have a call to action. What must we do? We must develop these recovery-oriented systems of care who are responsive to especially lived experience of people we serve. We must reduce the stigma, invest in community assets, and we must kind of expand access to treatment, long-term recovery supports, and elevate the voices of those who are often on the margins of our society. And I just want to say, definitely recovery is possible, but only when we try at least to remove these barriers that stand in the way. Thank you. David?
Okay, now David is speaking something, but it's my turn, I think. Sorry. What was amazed during all this research, it was that these three pillars that came out, it was so simple on the end. Yes, we know that recovery is a strength-based concept. And we know, that there are many barriers on this recovery path, for the people who wants to achieve recovery. But basically, when we put that everything into the three things, it seems to be so simple. So even our narrative change in the way of when we want to describe what really recovery is, that recovery is really concept that is based on the strengths, but many barriers are really influencing our outcomes. But on the third pillar, we really need to take attention, that are systems. Because even we all know that if we don't have any kind of system, recovery still will happen. If we are struggling with money or not, if we are connected or not with other organizations, if we are working in isolation or being a part of big networks, recovery naturally will happen inside of the people, because the people are in need of change and to come out of that problematic drug use. But still, who is in that field wants to see some pragmatic systems that will show us, that if we are investing in that kind of systems, that we will see some better outcomes. And I think this is the wish of everybody who is working in this field, So I'm really struggling and trying, to be a part and to see different systems that are functioning, where the people really wants to go out of the problematic drug use, that get some kind of help that has not so much barriers inside of them. But let's look what all that organization responded, So what came out of their responses? So basically, one of the responses was that the partnership models needs to recognize the process, holistic system, not isolated treatments, emphasizing community partnership, must foster personalized pathways to recovery to accommodate these changing needs. Also, involvement of peers and communities in pathways. So the role, as Mulka mentioned now before, the role of lived experience expertise need to be at the heart of recovery-oriented systems of care. And this is everything nice said, but let's look into the reality. Do we have involvement or enough involvement of lived experience inside of some different public systems, health systems? Are there some announcements for the job that you as a recovered users can apply and be some kind of recovery coach in some public health services? That's a very big question. How big is the involvement and the role of lived experience, and how we can create systems that the role of lived experience this is shown and this is expertise, it has influence on that all recovery paths. So evidence-based recovery also. So to create some systems needs to be recognized collaboration between academics, practitioners, and experts. And this is exactly what we are doing today. So we are combining different views and of course calling always academics and experts to help people in recovery to provide the right evidence-based infrastructure for recovery. And also funding. If we go and evaluate in our countries, in our communities, how much funding is going to some systems that are recovery oriented and how much some other systems are supported, we will come not to so good results. It depends, of course. In some parts of the world, maybe yes, in some communities, yes, but I'm thinking there are systems that needs to be really revised and funding that we need really to advocate for, that we can together, of course, with the funding providers, because I'm not thinking that recovery should stay only in communities and only inside of NGOs. Recovery needs to be accepted from the most of public health perspective. And integration of recovery across demand reduction, it may be something that we mostly 70% of responses agreed, so I've been looking through that. So everybody's been telling, that strategies and support that needs to be integrated into the various stages of a recovery process. So encompassing harm reduction, early intervention, treatments, resocialization, and long-term recovery management. And I'm sure, that sometimes that can be only the word on the paper, how to combine harm reduction with recovery, so this is also possible, but I think that we need to sit together and see what are really therapeutic goals from one side, our therapeutic goals from the other side, what are the really need of the people. Also, how to combine the proper treatment that is sometimes a long-term treatment, that sometimes it's only inpatient treatment in the different hospitals, how to combine that with some recovery-oriented systems of care where we want to see building more strengths inside of people, how to get a good resocialization program and long-term recovery management. So basically, when we think about systems, there are more question marks than some clearly response and answers, but still I think this document brings some common ground from all organizations to look in which direction we can go when we want to build this system. So basically, it's a tool for us and the knowledge for us in which direction to go. We are still not there when we think about systems, and it will be never perfectly. And I'm not telling that inside of systems we need to say recovery is the most important thing, let's forget about prevention and everything. But we really need to ask ourselves in different countries why recovery is not part of the policies, why is not part of the strategy, why not so much funding is giving to recovery, and why is this so different. And when we see the needs of people, when we see the needs of people, we should see, that much bigger systems should be built. But when it comes to policies, it's not like that. So basically, after we finished, as David said, after we finished that paper with these 3 pillars, we give that to different organizations, individuals, to sign, to see if anybody agrees with that, what we provided now, if we can have some followers after, and we got pretty good results, let's say. So basically, we get 650 signatories from 207 different organizations and more than 400 individuals. We had also 4 observers. So basically, we didn't want only to be inside of NGOs or people in recovery, or to send it to the different organizations, even prevention and harm reduction and early intervention organizations, but also to have some kind of political observers. So UNODC was behind this document, also Croatian Office for Drugs and Serbian Office for Drugs. So as you heard, UK was participating inside events in the UN. So basically, this is not only documents that we made to satisfy our work, then also to present it and be followed from the different governmental organizations. So we get the signatories from the different countries from all 5 continents. We see Asia mostly more than 200, but Europe, America, and Africa also very good spread with a lot of signatories from there too. So basically, we are continuing to spread this document for signing. And also now, David, please continue with some kind of recommendations and the future work.
Thanks, Boro. I'm aware we've been going for an hour, so I'm not going to talk very long with the recommendations, because I do want to leave some time for dialogue, comments, and questions. I think there was 3 broad areas, and I think also lots of the recommendations have come up in both Boro, Malka's, and my kind of commentary as we've been talking about each of the pillars. The recommendations have been inherent in some of the strengths or the barriers and issues that we've spoken about. The first domain around the recommendations was around service delivery and recovery support services, the need for that collaborative multidisciplinary approach of healthcare, therapists, counsellors, all having equal status and lived experience being at the heart of that, with education and training and quality standards, again, being paramount for ensuring that the best practice approaches are being used. Just to share 2 from that first domain. And then looking at domain 2 around public policy, it's really important that, so the meeting that Malka and I were just in this morning with the UK government was around, actually, will we give voice to those who are typically marginalised, and to what extent does lived experience inform policy making? Do we allow them a seat at the table to begin to challenge and share their perspectives? We talk about kind of challenging stigma through policy, but actually it's very hard if you come from a place of privilege without that lived experience to understand the feeling of worthlessness and a lack of hope that people have felt when they've been labelled and denigrated and called derogatory terms. So having them within those policy-making discussions is absolutely key, and ensuring that your policies are vibrant and alive to lived experience was a key point. And then in terms of the third domain, community and lived experience involvement, again, links a lot to what I've just said around that representation, but not just a policy. We know that in terms of recovery models and recovery practices, they're typically based on outdated white Western European male perspectives, and they've never really been fully replaced. And so the dominance of medical positivistic kind of forms of practice, although do have value and do have a place within the system, if that's the only type of offer, if that's the only model dominating, then I think we're missing a whole kind of 2/3, if not more, of what also needs to be part of the design and delivery and the evaluation methods. And I think that hopefully what you picked up from this paper was actually how we acknowledge that there are many different forms of knowledge, that there are many different perspectives that we wanted to be at the center of the table. And so that's a key kind of recommendation, that we don't work and operate in silos. So Boro, do you want to do the final slide? or if someone turns it to the next slide, yeah, I can do it. So I guess a call to action would be that you would scan the QR code on the left to sign the PPR paper, have a read through, of course, make sure that you're in agreement with what is written there, but it would be great if you would sign it, or if you've already signed it, can you share it in your network, to your allies, to people that you know that work in this field, and also join Recovered Users Network. This is a unique policy-making platform that places lived experience at the center, and really what I call epistemic participation. When so often those voices are ignored and not included, Run really offers this approach that voice is at the center. And what that means is the understandings of what recovery is, it broadens and expands. So what you have is something called kind of heuristic participation, that the knowledge base expands and grows because we're considering into the melting pot of what we already know all of these additional perspectives, and it shakes up what we currently know, and then what gets created is something new. And that goes back to the origin of why we did this paper in the first place. That I remember Malka's excitement at the CND in 2023, kind of saying, we've really got to bring greater unity, we've got to bring people together, and if we're not working together, we're missing the point, because being right is not a strategy. That's what the whole message of this paper is about. Being right, your paradigm, your thinking is not a strategy for helping and supporting and reaching out to others, working with others. And so really that's what we want to leave you with, to expand beyond your own silos and your own networks, to reach out to people perhaps who do work very differently to you. Can you kind of offer to go and visit their service, their organization for a day? Will you invite them onto your board, onto your kind of committees, so that we're beginning to have an exchange of views and learn from each other? And as we rub up against each other, we can hopefully also learn from one another. So thank you so much, everybody, for all of your participation. And you've been listening for a long time. So I think we're going to open the floor for comments, questions, disagreements, diverse perspectives. Thank you. Lindsay, over to you.
Thank you so much to our speakers. That was incredible, very thorough and a powerful presentation. A lot of great work that's being done through the survey and will continue to be done in our communities globally. We definitely have some time for our questions, and they've been flowing in the Q&A box. I'll read a few out, but just as a reminder, feel free to continue submitting questions using the QA box. I'll pose a few to presenters now, and then we'll see if any more come in as we do have some time before we need to wrap up. So one of the first questions I wanted to start with was, what progress is there with long-term recovery? That is globally, what is the most recent about the continuum of care specific to long-term recovery?
I've got an initial response, but I'll pass over to my panel members as well after me. But I think that in terms of the long-term recovery and that continuum of care, I think some of the work of Professor David Best around inclusive recovery cities and challenging the notion that, as he powerfully does, that recovery doesn't happen in a clinic or just in a clinic, it also happens in the community and within cities. And so trying to build these ecosystems that actually recovery is everyone's responsibility within a city. Everyone's a stakeholder. That actually the pathways that we cultivate in our everyday lives to make them inclusive, kind, compassionate, providing those progression pathways for us all to thrive. I would offer that model as one of the most innovative things that are helping to progress long-term recovery. But I'll hand over to Bora and Malka for any other comments. Oh, yeah, I think you're muted, Bora.
Okay.
You're muted, Bora. Okay, I will just say that almost 23 3 million of Americans only are in recovery, and that number increases every day. And recovery is something that doesn't happen in a clinic, and we do not have all the data about recovery and long-term recovery. And this is why we want to unite and do the research more, and also kind of change the measurements and narratives around the recovery. So how do we measure recovery, and what's recovery? How do we kind of unite the voices of recovery movement to show that recovery is there, visible, possible, and that people recover every day? So I think that's a good question, and we are trying really hard to contribute with our knowledge and experience and work on the field to expand our knowledge about the long-term recovery. But what I can say is that commitment to continuum of care and long-term recovery support to initiate, sustain, and maintain recovery need to be prioritized. And this is because not only because of the individuals, this is because of the families, this is because of the communities. And what really matters is to show that it's possible, to show the hope and to show the other side of recovery that hasn't been really recorded in the books and in research.
And as well, you did start when you talking about the measurements. Sorry, Bora, do you want to chip in?
A little bit. Just when we hear about long terms, and sustainable something, that will possibly end one day, we have a lot of barriers inside of that, so who wants to support what does not have clear end sometimes, but long-term recovery needs to come inside of the ears of the people who are providing different services, because we are not treating in the first month of treatment of recovery program, we are not treating the whole person. We need to understand that there are really clearly, stages. And in the first year, you need to think about yourself and your attitudes and, and how to get off your problematic health, etc. But what is when you are coming out of some rehab or when you are part of community, who will give you a job? Who will give you education? So basically, long-term recovery needs to be understood not only from the perspective of people in recovery, then really the whole policymakers and public. So that doesn't mean that we will constantly provide services that are full cost with the fully costs, So this is, I'm thinking, that the people are always afraid of. Our long-term recovery means, that we need to invest. I don't think this is reality. I think this is more the module and more the narrative that we think people need support in the different stages of life, and continuum of care must exist. So I think when we speak in that way, we will find more understandable ground when we speak with the different service providers, not directly service providers. Then, for example, offices for employment, they will not be in all stages to provide job for the people in recovery, but in some stages they need to have open door for those people. David?
Yeah, I would just jump in as well and just say around when Milka was talking about the metrics and the measurements, that I think that we're now also moving away from just looking at individual factors of people in, the onset of addiction. We typically look at people who, when they were 5, this negative life event happened, and when they were 10, their parents divorced, and then at 13, there was sexual abuse or domestic violence in the household and poverty and so on and so forth. And then what happens is it's intentionally, the view is that it's people like them with those life experiences. And actually, what we're beginning to recognize is that there's something around the way in which we're all living that is very destructive and negative and harmful for all of our detriment. So that the onset of kind of dysfunctional behaviors and addictions, the degradation of well-being and quality of life, is something that's systemic and structural. It's not just people like them over there that are showing these kind of dysfunctional behaviors. And so, equally, in terms of long-term recovery, what we understand, what we're beginning to map out is kind of there's a culture of recovery, there's values and practices and norms of recovery that are good for everybody. And so recovery doesn't just benefit those in recovery. Go figure. So the finding that if people 5 years plus in recovery have got better quality of life and well-being than the general population is because they live differently now. They're not living in accordance with those old patterns and ways of living, of always putting on the fake self. Yes, I'm always fine, thank you. Of always being competitive or doing the job just for the money. They now live with meaning and purpose and creativity and true friendships. They turn up as their whole self. So long-term recovery is actually sustained by these pre-practices and ways of living. It's not about interventions or programs. So linking to your funding issue, Boro, governments can be scared of providing long-term recovery support, but actually, a lot of it's not about an accredited program. It's about practices and cultures of living. I'm going to stop now.
Yeah, I just want to add to that, David, and I like that slide when we talk about recovery. If you ask any medical kind of professional or even some other professionals, they will say it's a chronic relapsing condition, and yet recovery has long, for decades, been treated as acute condition. So it's like you're breaking a leg. Basically, you have a detox of a couple of weeks or some short rehab, and then you're out and about, and you're not anybody's problem. But uh, actually, in the definition, it should be long term. It is long term, and it's chronicle. So I think, for once, need to start behaving like it's a chronicle or change the definition, definitely.
Thank you so much. I wanted to do a follow-up question based on another question submitted in the Q&A box. Molokai, you mentioned the 3 million people obviously in recovery, and there was an instance as well where you mentioned families. Families aren't calculated in that number, right? And one of the difficulties that families supporting their loved ones, especially during, someone mentioned the first 3 stages of recovery, there's not even recovery services, familiar family support available really on the radar or available until kind of that action stage. And families are in need of multiple pathways to recover too. They make a huge difference, as we know, in particular when it comes to reducing stigma, advocating, educating, and outreach, and really just truly being some of our strongest allies. How do we kind of change the dynamics or work to change the dynamics in particular for family support of those in recovery?
Well, thank you so much, Lindsay, for mentioning that. Actually, what kind of came out as an outcome of this work in the past 2 years was that our collaborators and partners reunited again to create another initiative, which is a Global Family Alliance of Families in Recovery. And why is that? That's exactly because of those things, because families are not supported. We do not know even the data around the families and effect that addiction and recovery has on families. There are a couple of papers and reports, but we do not have the global voices of people with living experiences and family members and family organizations. So we have started actually to do that one more time and to repeat all of the collaborative processes that David has so kindly explained. And we are hoping that by the next CND, we will have another global position paper, which is around families and how to improve it. Because for us, as especially Recovered Users Network, as a policy kind of focused recovery initiative, we want to bring these voices and we want to kind of include families and provide a seat at the table with policy making, with national strategies, local and international initiatives to involve families. And we think that's really critical because, as we know, addiction and recovery do not affect only individual. It affects the family, the children, also our communities. So we are hoping we will discuss this matter very soon with all of you and share our new findings. I don't know if Bora or David want to say something. Sorry.
Good. Okay. David, Dr. Patton, do you have anything else to follow up on that?
No, that's fine. That's
okay.
good.
Perfect. We did have another question here. Someone is inquiring of whether or not we should give more emphasis to the meaning-making dimension of addiction and recovery. Meaning, should we be supporting people to digest what they want to medicate away?
Yeah, I think a lot of the methodologies that I use in my research, steering away from that positivistic scientific in the traditional sense of kind of just creating statistics and numbers for the sake of it, and using these more qualitative and being introduced by Mulker to photo voice. These are decolonizing methodologies. These participatory active research processes are all about meaning making. And those meaning-making spaces and places that people in recovery create, as Burrow powerfully said, if all of the services were to close down tomorrow, recovery would still happen. Why? Because the people come together and through their meaning-making, through their storytelling, through their solidarity with one another to raise each other up, to lift each other up, share what's worked, and to give of their finances, of their time, and their genuine listening and care and empathy to each other, and so much more. Recovery still happens. So meaning making for me is at the heart of kind of the knowledge production work that I do. It's why I set up New Central Media, which is a publishing kind of house, which we've kind of published a number of books, and we allow people in those books to become the authors of them, but the chapters are kind of, they're not censored in any way, they're not sanitized, they're not edited into academic garb, there's no requirement for them to refer to academic studies. It's their words, their world expressed on the page. And so absolutely, with whoever asked that question, meaning making is at the heart of healing and recovery, in my view.
Thank you so much. This question is particular to stigma. It's a really important one. How do we get a community, our neighbors, our workers in our grocery stores, petrol stations, our daily interactions with community members, maybe faith-based organizations. How do we get them, maybe some key takeaways for our audience of how to get them not to stigmatize a person in recovery, and how to overcome such discrimination beyond education, more of kind of that mindset shift that we're looking for.
Yeah, I will look from our side first. I think that our side, recovery side, needs more visibility. So, cause the stigma, we are sometimes not so encouraged, to speak, clearly in front of community people, in front of our neighbors, because we know, okay, if somebody knows, that I was drug addict for years and that I was in some rehab center, they will look at me not with the same eyes. But the reality is really differently, and this message we are really speaking. If you are living today drug-free life, if you are contributing to your community, there is no reason not to tell your story. Of course, maybe you will not go to the media, to the television, to speak in front of hundreds. But when it comes to that, it's much better to be open. And I'm thinking through the more visibility, stigma, we will have a less stigma. So basically, the response is not that society needs to change, because we want that. Response is we can do what we can do. People in recovery needs to be more open, whatever matters, whatever happened. So sometimes in our community organization, sometimes we are talking with the people. So when you will say to your employer that you've been 10 years in addiction, on your first interview, after first month, after first year, or after he finds out? It's a huge question. So basically, but there is a response and answers for that. So, David.
Yeah, I mean, it's a huge question. It's very complex, isn't it? And there's no simple one magic wand trick or answer or takeaway, I don't think. Or if there is, somebody put the answer in the chat box, please, so we can all do it. And I think we've got to come back to, stigma is there, and the reason why it's there because we live in this toxic culture where we've all got to be strong and everything's got to be okay all of the time. And so when we're all pretending to be okay and putting on this pretense, you put other people down. So it's legitimized to call somebody a junkie or an addict or a skaghead or whatever negative label may be because you don't feel okay. You see, because happy people who are fulfilled don't do that. They don't put other people down. They don't say negative things about other people. And so the one of the takeaways, I think, how can we all be more authentic in the spaces we inhabit so that when we come into meetings, the workplaces, the family home, the conversations with the neighbors, that we don't just jump to, hey, I'm doing fine, thanks. That we communicate it's okay not to be okay. And actually that we all give ourselves grace for the mistakes that we've made ourselves, that we become more compassionate with ourselves in order, firstly, that we can then be compassionate with other people, because that's at the heart of stigma. How can you be compassionate with other people when you first have never given it to yourself? So for me, those are some of the practices that I'm turning 50 later this month. And so I'm still learning to let my belly out, to share my failings, and to be compassionate and kind to me that I may kind of continue to do with other people.
So,
Yeah, thank you, David. I just wanted to kind of, well, say it again. We need to reduce stigma, not just about, it's not about act of kindness, it's about justice. So we really need to think about the social inequalities. And first, what Boris says, recovery needs to be visible. It needs to be celebrated. We celebrate birthdays, weddings, all of those things, but we do not celebrate recovery. And across America and across the UK, there are large happenings, celebrations of recovery, recovery games, family days. And I think that's the first thing that every society needs to do. And that's why we kind of promoted these inclusive recovery cities, which do have a task to have 4 big events each year to celebrate recovery. This really promotes the access to community resources. This kind of promotes the families that are happy when people are in recovery, but also meaningful social roles that people now have across the stages of recovery processes. And I think it's about ensuring that every person in recovery really has the opportunity to fully participate in the society as a meaningful contributing member, and to have all the rights that people who never had addiction problems already have.
thank you so much. And one quick kind of takeaway that I have practiced in my work in particular is if someone is person's first language, obviously, and the use of that. A lot of times, if I'm out about and I hear an individual, whether it's with a person checking me out at the grocery store, or helping me, to pick up my kids and put them in the car and things like that, and I hear someone use a word in terms of addict or stigmatizing language, a lot of times I just rephrase what they said to me using person with substance use disorder. And it doesn't happen the first time. It might not happen the 5th time, but I have tested this quite a bit, and it eventually changed that mindset where that person first language allows that compassion to kind of resonate more about identifying them as a person, not solely by this disease. And that does go a long way without, as some people worry, that when we're constantly, especially during, political parties and election years that we're constantly faced with like flyers and information to try to educate us to sway one way or another, right? It's a way that is educating more in that mindset shift instead of just simply trying to educate a person, which sometimes people find offensive or don't want to be proven wrong, right? So that has been really helpful that I have seen. But I do want to make note that we will have two different webinars specifically through the series. One that's particularly focused on words matter and stigmatizing language, as well as particularly on the power of storytelling, so that we can dive even deeper into that conversation. Because as Dr. Pat mentioned, I mean, this is a difficult question to answer. It has multiple different levels, and I'm not even positive that we have like the one answer, right? And it's constantly evolving. So thank you for that feedback. We're going to go ahead and close up. We've had some really great questions. I welcome you to continue maybe asking those and engaging with us, that myself and ISSUP can follow up with the panelists to get you all connected as well. As we've heard today, and know very truthfully, recovery is not a one size fits all. It is shaped by personal experience, culture, access, and community support. As we continue this journey together, we invite you to really reflect on how your work can honor and uplift those affected by substance use disorder, those with lived and living experience. And again, I just want to give another thank you to our presenters for helping us continue with this series with such depth and heart. And thank each of our audience members for being present with us today. Just a few things as we close up. As a reminder, you will receive a follow-up email with the webinar recording, slides, and additional resources. We ask you to please take a moment to complete our short feedback survey. We love your thoughts and feedback. It allows us to really go back to the drawing board, brainstorm exactly what you need, and to embark more on training opportunities and resources, really to just impact your communities. Otherwise, we will see you again in 2 short weeks at the same time as we continue our foundations phase to close it out with understanding recovery-oriented systems of care, ROSC. Until then, thank you again and take care, everyone.
Thanks, everyone. Take care.